Welcome to this video on the clinical management of elite dancers. We will explore essential training pathways, biomechanics, and evidence-based injury rehabilitation protocols designed for professional dancers. When seeing young dancers, they are typically not doing highly demanding routines just yet. One of the biggest advantages we have is that they are used to discipline. They are very accustomed to doing what they're told, which greatly facilitates treatment. If you propose modifications like no jumping, stay flat, or legs low, you should also get buy-in from both the dancer and their teachers. The key is taking a long-term view of their training program, asking what they need to succeed overall rather than looking for a shortcut to get them through a performance right now. At the elite school level, the curriculum progressively builds up the amount of dancing, which has to be slotted in alongside their regular education. The demands are massive. Some will commute an hour or more each way and then do virtual school at the end of the day. Elite training demands a multifaceted approach. This includes mastering classical techniques, such as character and partnering work, maintaining a high strength load through targeted conditioning, and balancing rigorous physical demands with academic education. Within the programs, they learn classical ballet, character dance, partnering, and overhead lifts. We also educate them on anatomy, nutrition, and performance psychology. Because of this education, when these dancers come into the clinic and you mention the FHL, they actually know exactly what you are talking about. Understanding footwear is crucial. The block of a pointe shoe is actually made of old-school papier-mâché and polished with shellac. While principal dancers go through several pairs a week, students often expect a pair to last a year, which they don't. A common misconception is that dancers balance directly on the tips of their toes. If you x-ray a foot on pointe, it's actually more like a socket fit for an amputee's prosthesis. The shoe is firmly fitted around the metatarsal heads, which holds the foot in place and leaves a little bit of freedom for the toes. To manage moisture and comfort, dancers frequently use blue and white Chuck's kitchen wipes inside the shoe. Moving to specific injuries, the feet and ankles take a massive beating. In youngsters around 10 to 13 years old, they will often come in complaining of what they think is Achilles tendinopathy. In these dancers, because of the repetitive rising up onto the toes and full plantar flexion, it is posterior impingement until proven otherwise. While Seaver's disease is the common culprit for posterior heel pain across the general sporting landscape, the specific mechanics of ballet point directly to impingement. From about age 16 onwards, our big concern shifts to the anterior cortical stress fracture of the tibia. This is very much associated with vertical jumping patterns, similar to what we see in basketball or volleyball. The classic presentation is a dancer mentioning a sore, tender, bony bump right on the anterior tibial border. As soon as you feel that bump, you need to get an x-ray. You are looking for a focus of stress. While multiple small adaptations to bending are normal, a single focal crack at the mid-tibia is the one that is much more likely to snap, especially during heavy load periods. When it comes to imaging these tibial stress fractures, I am strongly of the view that X-ray is our best modality. Because we are dealing with cortical bone, MRI will sometimes miss these things entirely. X-rays offer a low radiation dose, are easily repeatable to track progress, and with digital imaging, we can enlarge the area of interest to get a great look at what's going on. While you might use an MRI if you lack clinical control over the patient's workload, serial X-rays are incredibly effective when you know the dancer is sticking to their modifications. The most important takeaway for cortical bone injuries is that they take a very long time to heal. Most osteoporosis medications are designed for trabecular bone, not cortical bone, so there are no proven pharmaceutical shortcuts here. The cycle for cortical bone remodeling is about 100 days, and we often need 2 or 3 of those cycles to succeed, meaning 200 to 300 days of healing time. Orthopedic hardware like rods or plates don't flex when the dancer jumps, which causes ongoing pain. The body simply has to do the work, and we have to be patient. The standard 6-week orthopedic timeline is completely inadequate in these circumstances. Ultimately, patience is the primary prescription. Effective rehabilitation requires strict load management and careful structural monitoring, ensuring the dancer yields to biological timelines to ensure a safe and successful return to performance. Thank you for watching and listening to this overview on the clinical management of elite dancers.